Welcome everyone for the class on recitation. So this is the part one of the recitation. Again, we'll be discussing in two parts recitation. So this is the part one. Next part, we'll be discussing all the recalls. So whatever we are teaching you in the recitation chapter is directly taken from Recitation Council of UK. Okay, it's nothing going away from the Station Council of UK. Everything what we teach, even a single word what we teach you or what I'll be teaching today will be taught from the Station Council of UK. That holds good for your MRCM exam. Anything out of this is not good or it is not applied to your MRCM exam. For example, if you're following AHA guidelines, you're following ACLS, those are more concerned or those are more related to USA. It's not related to the UK. So you need to stick to the Recitation Council of UK, except for trauma. Trauma, they do not have cardiac arrest trauma, how to deal with it. In NHS, they follow the European guidelines. We'll be looking at the European guidelines today. Except that part, rest of it is from the Recitation Council of UK. First thing what we'll be looking at is a basic life support. So we are starting from the basic life support. Basic life support, if you go through their Resuscitation Council of UK, they have two settings. One is community setting, what they have. Another one is the hospital setting, what they are having. So what we'll be seeing is the community setting, what we are having. So if the patient is unresponsive, not breathing normally, directly you will call for the help. Then you start on the chest compression. You can see there is a point which is missing. We usually, most of us are aware that we need to check for signs of life. So signs of life, you're not checking in this patient. Why are we not checking for any sign of life in this patient? The main reason we are not checking the sign of life in community settings is these are the community people who will be checking for sign of life. For example, it might be a school teacher who might be checking, or it might be a bus driver who might be checking. They may not be well versed how to check a sign of life. Feeling and carotid pulse in a panicky situation is difficult. For that particular reason, they have advised if the patient is unresponsive or not breathing normally or not breathing at all or agonal breaths are present, start with the CPR immediately before that call for help. CPR, that is chest compressions, you will be doing 30 followed by 2 rescue breaths. So you will be doing 30 chest compressions to 2 rescue breaths and you will be continuing this till an AED is available. AED stands for AED stands for Automated External Defibrillator. Once automated external defibrillator is available and you are connected, then it will direct you. It will give the instructions. It will say, stand by. All of you be away from the patient. Rhythm is being assessed. Time for to deliver shock. All clear. Shock is delivered. Continue CPR. So it will instruct you what needs to be done. That's why it is known as automated. So an automated external defibrillator will be connected and it will be continuing. What about in the hospital setup? Whenever there is a collapse, the sick patient, you immediately call for help and check for signs of life. The important sign of life, what you need to really check for is carotid pulse. Okay, is the carotid pulse or the central pulse, what we call it. Is the carotid pulse, which is the preferred one in an adult. So you'll be checking for the carotid pulse. Yes, you are able to feel the carotid pulse and you're sure about it, then it is a medical emergency. Then you will be following an A, B, C, D, E assessment. No, you're not sure about it or you have not felt the carotid pulse. That means you will label that patient as being in cardiac arrest. If you're not already called for help, please do call for help now because cardiac arrest, minimum of 5 people are required. Start with high quality CPR. There is 30 chest compressions. You will be doing it. Then followed by 2 rescue breaths you will be giving. So the ratio is 30:2. You will be continuing doing this till you have connected to an defibrillator. Once you're connected to a defibrillator, you will stop the chest compressions and assess for the rhythm. That's when the advanced life support starts in. We are expecting by this time you will be having an cardiac arrest team available in your hospital or have arrived by this time, and they will take over the case. And that's what is happening here. So you will be handing over. So basically, to summarize everything and put it, this is what you need to remember. First thing what you will be doing is make sure the maintain personal safety pressure or make sure the scene is safe first. Okay, this is mainly applicable when you're outside hospital. For example, there is an radiation exposure and someone is unresponsive, that it might not be safe for you. So make sure you are safe first, then enter into the scene. Once you made sure it is safe, then you go and check for response. You'll tap on the shoulder and ask him, sir, are you all right? Or ma'am, are you all right? No, there is no response at all. Immediately call for the help. That is the step 3. Once you are called for the help, then you will be checked for the signs of life. The important one is the carotid pulse, what you need to check for. If carotid pulse is absent, then you will start the CPR at 30:2 ratio, connect the AED, that is automated external defibrillator, and follow all the instructions what is being given on the automated external defibrillator. What if there is signs of life present, the patient is breathing and carotid pulse is present, then it becomes a medical emergency. So what you'll be doing is you'll be going airway, you'll be assessing the airway, you'll be assessing the breathing, circulation, deformities, and external extremities or exposure, what you are basically looking out for. It's a medical emergency, what you need to remember. This is about basic life support. Technique is important. How do we give and chest compression? Where do we place our hand? The heel of one hand, as you're seeing here, heel of one hand should be over the lower one third or lower half of the sternum. It should be placed. With another hand placing over it, it should interlace. The fingers should interlace each other. Your elbow should be locked. Shoulder should be right above the palms, what you are having. Then you need to start compressing. At what rate you will be compressing? You'll be compressing at a rate of 100 to 120 per minute. This is the preferred rate. It should be somewhere in between this. At what depth you will be doing it? 5 centimeters. It shouldn't be more than 6 centimeters. Okay, somewhere between 5 to 6 centimeters is the ideal depth what you're doing it. It shouldn't cross more than 6 centimeters in an adult what we are talking about. You might get tired because you are continuously doing this chest compressions. So the recommendation is every 2 minutes when you're checking for the rhythm, interchange the persons who is doing chest compression, change him. He may not be able to give adequate chest compressions or quality chest compressions because he's tired. So change him. So you'll be doing in a ratio of 30:2, 30 chest compressions to 2 rescue breaths you will be continuing. If you are trained at putting or placing up and supraglottic airway device, please do place it. Coming to the rescue breaths. When you are giving an rescue breaths, use an chin lift or jaw thrust technique while you're giving an rescue breath. Jaw thrust technique is not preferred or it shouldn't be done or it is contraindicated in an trauma case because it might worsen cervical spine injury if at all, if it is present. Otherwise, you can use, jaw thrust technique is preferred in trauma. You shouldn't be doing head tilt chin lift technique. This is contraindicated in trauma. This is preferred in trauma. That is, jaw thrust technique is preferred in trauma. Jaw thrust technique preferred in trauma because if there is a cervical injury, it will not worsen it. If you're doing a head tilt chin lift maneuver, if there is a cervical injury, you will be worsening it. For that particular reason, in an trauma, jaw thrust technique is preferred. In a medical emergency, you can do an head tilt lift maneuver or a jaw thrust maneuver, whichever you are comfortable with. Each rescue breath should be given over a second. Okay, at the same point of time, look at the chest rise. There should be an adequate chest rise. If there is enough chest rise is present, or you are able to appreciate the chest rise, that means you are giving an adequate breath. While doing this, for example, while you are interchanging the compressor or when you are checking for the rhythm or when you are connecting the AED, make sure when you stop the CPR because you want to intervene, it shouldn't be more than 5 seconds. Make sure it is less than 5 seconds as much as possible. This will make sure the blood supply to the brain remains continuous in a uniform manner. If you make it more than 5 seconds, for example, 10, 15 seconds, that means the patient might go brain dead. Even if you get a ROSC, it will be useless. The patient will be brain dead. So no point in continuing the resuscitation if you're interrupting more than 5 seconds. So make sure it is less than 5 seconds. Whenever possible, connect a manual defibrillator. Manual defibrillator is always preferred over an automated defibrillator. And you will be assessing the rhythms every 2 minutes. Now we are entering into an adult advanced life support. So you started the basic things. So you made sure the scene is safe. You checked whether the patient is responsive or unresponsive. Is unresponsive. So after that, you are immediately called for the help. Then you check for signs of life. No carotid pulse is present. That's when you have started the CPR and connected to an manual defibrillator. As soon as you connect to a manual defibrillator, it may not be 2 minutes. This is the confusion usually people will have here. So let me repeat it. As soon as you connect the defibrillator, it might be 1 minute from the time of onset of the CPR. It might be 30 seconds, or it might be 3 minutes from the onset of the start of CPR. Doesn't matter what is the time. You will immediately stop the chest compressions to assess the rhythm. What you will be assessing for? You will be looking for, is there any shockable rhythm is present? Shockable rhythm is shockable rhythm is ventricular fibrillation. This is what, or it might be in VT, it might be in polymorphic VT, or it might be in monomorphic VT. If any of this rhythm, the top three rhythms, what I'm showing here, if any of this is present, then it is known as shockable rhythm. Okay, you have to deliver a shock. Of how many joules are you delivering it? 150 joules. Immediately deliver the shock and continue the CPR. One more mistake what usually people do is after delivering the shock, they will check again for sign of life. That means they will check for carotid pulse and start assessing the rhythm. No, do not do anything. Continue for the CPR for 2 minutes. Once you continued CPR for 2 minutes, again you are assessing the rhythm. At this point of time, it may be a non-shockable rhythm. What is non-shockable rhythm? It might be an asystole. Okay, it's a flat line, asystole. What you're seeing, this is completely an asystole, a flat line. There's some blurring will be there, but it is a flat line grossly. This is known as asystole. Or else there might be an pulseless electrical activity. So you are seeing an electrical activity on the monitor, but you're not able to feel the carotid pulse. That means there is no pulse, but electrical activity is present. This is known as PEA, pulseless electrical activity. This is also a non-shockable rhythm. This pulseless electrical activity, the rhythm what you're seeing on the monitor, can be anything other than the VT and VF what we have discussed. Other than these three rhythms, it can be anything. What do you mean by can be anything? It can be an SVT. It can be an atrial flutter. It can be an atrial fibrillation. It can be atrial fibrillation. So it can be any rhythm it can be other than ventricular tachycardia and ventricular fibrillation. With any other rhythm, there is no pulse, then you call it as an pulseless electrical activity. Treat it as an pulseless electrical activity. Do not get confused at that point of time. Along with, so if it is a non-shockable rhythm, what we do? It is a non-shockable, so you cannot deliver the shock. Immediately, you will give first dose of adrenaline. Okay, adrenaline is 1 mg what we are giving it. Okay, it's a 1 mg. If you see an ampule, it comes as an 1 mg. Any adrenaline ampule, if you go to the emergency department, if you pick up an ampule, it is an 1 mg ampule what you are having. This, you need to dilute it to make it 10 ml total. That means this is in 1 ml, 1 mg is in 1 ml. Add up 9 ml more of normal saline. So it will become 10 ml. So you're dilating to the ratio of 1 is to 10,000. Because in the ampule, what you're having is 1 is to 1,000. Most of the time they make mistakes here also. That's why I'm pointing out and stressing on this. You need to dilute it, then you give it immediately in the crash cart. That means in the emergency department, in the resuscitation bay, they would have preloaded and kept it so that there is no delay. If the patient arrives in cardiac arrest and if it is the patient is in non-shockable rhythm, you will immediately give the first dose of adrenaline. Then you will repeat every 3 to 5 minutes. You keep on repeating every 3 to 5 minutes. Additional thing what you need to remember here in the shockable rhythm is first 3 shocks you give, but no medications you're giving. After the third shock, you will give the patient adrenaline as well as amiodarone. Once adrenaline is given, it is repeated every 3 to 5 minutes. Once amiodarone is given, next dose of amiodarone is given after 5th shock. What is the dose of adrenaline? It remains the same what you give it in a non-shockable rhythm. What is the dose of amiodarone? After the third shock, you will be giving 300 mg IV bolus. After that, that means after the fifth shock, not after the fourth, after the fifth shock, you are giving 150 mg IV again bolus. IV is preferred over intraosseous. IV is the choice, the drug of choice, route of choice, basically. If IV is taking delayed or you're not able to place it, then you choose an IO, that is intraosseous line. Few more things what you need to remember. If you're skilled enough, you have an anesthetic, a senior anesthetic, while ongoing CPR, you're able to intubate, or the anesthetic is able to intubate, go ahead and place an advanced airway or an supraglottic airway device. So an endotracheal tube or an supraglottic airway device, you're placing it. Once you have placed it, then you're approximately giving 10 breaths per minute. Per minute, 10 breaths you are giving it. So what we usually do is the one who is in the airway, he counts for 5. 1, 2, 3, 4, 5. So 5 seconds it will be. Then he'll be giving one breath. Or he'll be counting till 6 and giving one breath. So it will be around 10 to 12 breaths what we will be giving. That's the approximately how we will be calculating and giving it in a real scenario. That's how you need to remember. So every 5 to 6 seconds, you will be giving a breath. In other words, you'll be giving around 10 to 12 breaths per minute. Both means one and the same. One is saying 5 to 6 seconds, you give one breath. Another one is saying 10 to 12 breaths over a minute. Both means the same. Do not get confused. Once you have an once you have an advanced airway, like a supraglottic airway device or an tracheal tube, start just compressions continuously. Do not stop in between. We say after 30 compressions, stop. No, you're not stopping it. What you're doing is you're continuously compressing the chest for 200. Okay. And in between, every 5 to 6 seconds, you are giving one rescue breath. So you'll be continuing this up to 200 chest compressions, then you will be checking the rhythm. 200 is approximately given over 2 minutes. So after 2 minutes, you check the rhythm. So all mean one and the same here. Especially when you are using a supraglottic airway device. For example, you are using a laryngeal mask, LMA you are using, or an eye gel you are using. You feel there is a no good seal. There is some air leak is present. If you're feeling some air leak is present, you feel the ventilation is not adequate, then you stop the chest compressions. After 30 chest compressions, stop it, give 2 rescue breaths and continue. Okay, you're not giving it continuously. If you feel there is a gas leak, if it's not there, then you continuously give the chest compressions for 200. In between, you will be giving every 5 to 6 seconds, you will be giving rescue breaths. Use waveform capnography to always confirm that endotracheal tube is in situ. That is the preferred one. The best choice is to directly visualize the ET tube passing through the vocal cords. The second best thing is to check with an EtCO2 monitoring. That is nothing but waveform capnography. End-tidal carbon dioxide monitoring, that is known as EtCO2. It is measured with an waveform capnography. Along with it, you can also see how's the quality of CPR. Sudden rise of EtCO2 in waveform capnography, if you can see end-tidal carbon dioxide values suddenly increased, it might be suggestive of an ROSC. Most of the time, that is 99% of the time, it is suggestive of an return of spontaneous circulation, which is known as ROSC. That doesn't mean you stop and start doing an ABCDE assessment, that is post-cardiac arrest assessment. You need to check other signs of life are also present or not, especially is there a pulse or not, what you need to check. That's what it means. However, chest compression should not be interrupted based on a single sign alone. That means if there is an increase in EtCO2, look if the patient is started moving around, or look for any other signs. Are you feeling the pulse? You can briefly start for the CPR and check for the pulse if it is present. If not, continue CPR. Do not stop it completely, what this phrase means. Always mechanical chest compressions are preferred compared to a non-mechanical, mechanical chest compressions are always preferred. What do you mean by preferred? That means high quality manual chest compressions are much better than using any machines. Okay. For example, there are many mechanical chest compressions which are present. They're not good enough compared to a manual chest compressions. If you are getting tired, if you do not have enough manpower available, at that point of time, you can use an mechanical chest compressions. Otherwise, manual chest compressions are preferred. Manual means you doing the chest compressions. A human being doing the chest compressions is much better than an device doing the chest compressions. This is what is happening. So what we are doing here is, so once you have the patient in a cardiac arrest, you start the CPR and you continuously check the rhythm every 2 minutes and intervene accordingly what has been set. Doing this will not achieve an ROS, that is return of spontaneous circulation. You will not achieve it. How you will achieve it? You need to see what has caused this cardiac arrest, why this patient is having a cardiac arrest. Over a time, multiple research has been done and they have come up with reversible causes for an cardiac arrest. What are the possible reversible causes for the cardiac arrest which you can immediately intervene, which will help you to get an ROSC in that patient? What are the reversible causes? There are 4 H's and 4 T's. While you're following the cardiac arrest algorithm, at that point of time, in your mind, you should always check for, are there any reversible causes? Is the patient hypoxia which has led to it, hypovolemia or any electrolyte imbalances or hypothermia? Is there a cardiac tamponade or toxins, or there is a thrombus in coronary or pulmonary artery? Is there a tension pneumothorax which has led to an cardiac arrest? If yes, you will intervene immediately. Once you intervene, the chances of achieving ROS, return of spontaneous circulation, increases drastically. A bedside ultrasound is used a lot nowadays, and it is very helpful, especially in the cardiac arrest scenarios, to find out the reversible causes. So each one of these H's and T's what we'll be looking out for. Hypoxia. Hypoxia is anyone having a respiratory disorder and undergoes an cardiac arrest and hypoxia is present, or it might mean foreign body inhalation, or it might mean severe edema which has obstructed the upper airway or a lower airway that has led to an low oxygen levels. Okay, nothing much drastically can be done for this because you would have started with back mask ventilation. If you have expertise, you would have placed in supraglottic airway device other than tracheal tube. Next one is hypovolemia. Hypovolemia, fluid loss. Hypovolemic shocks are multiple causes. Traumatic hypovolemia might be there, hemorrhages might be there, an upper GA bleed might be there, a gastroenteritis might be there, third spacing of the fluids because of an sepsis or because of burns might be present. What you do? If there is a fluid loss, you usually replace it with the fluid. If there is blood loss, we prefer to replace it with the blood, giving an PRBC and FFP. Blood and blood products are preferred. But most of the time in the emergency department, blood will not be available immediately. It has to come from the blood bank. In the meanwhile, you can resuscitate with the fluid till the blood products are available. For some odd reason, if the blood is immediately available, resuscitate with the blood. If you think the hypovolemic cardiac arrest cause is because of an hemorrhage, use blood and blood products. If you think it is not because of an hemorrhage, just use fluid. Not any fluid. Crystalloid fluids are preferred. More likely, it is an ringer lactate which is preferred, also known as Hartmann's fluid. There is a slight difference between Hartmann's fluid and ringer lactate, which we'll be studying in coming up classes. Electrolyte imbalance. The H starts for hypo or hyperkalemia. It doesn't end there. It's just not talking about the potassium. We are talking about potassium, calcium, magnesium. These are the 3 electrolytes what we are talking about. Especially if it is an hypomagnesemia, it can be a polymorphic VT which has led to an cardiac arrest. So you need to check for potassium, calcium, and magnesium. Potassium and calcium are usually available on a blood gas. Magnesium might not be available on a blood gas. At that point of time, you need to collect the sample and send it for the lab to check for the magnesium. So all 3 electrolytes, potassium, calcium, magnesium, what do you need to look out for? You might have to check for the glucose also, but multiple studies have shown that glucose itself by itself unlikely to cause an cardiac arrest. If it is low potassium, you're replacing with them potassium, obviously, but you cannot give it as in flush. You need to give it over 20 minutes, 20 millimoles IV. Next, then again, you will be rechecking and seeing whether the potassium levels are come back to normal or not. If not, 10 millimoles IV over 5 to 10 minutes, you will be repeating the doses till it comes to the normal level. If it is low magnesium levels, especially if it is less than 0.65, then 2 grams of IV over 1 to 2 minutes, you can give it. Hypothermia, low, low core body temperature, especially if it is less than 27 degrees Celsius, the patient will end up being in cardiac arrest. To reach such a low body temperature, you might need special thermometers, or sometimes you will realize that this is hypothermia because the body is very cold and the thermometer is showing an error because it is so low it is not able to pick it up. Then you need to start the active rewarming for this patient. There are various techniques to rewarm. The simplest ones is to remove the wet clothes if they are covered with, make sure the body is completely dry. And what they'll be doing is increase the room temperature so that everything seems to be warmer. Then they will be covering up with the blankets, especially bear hug, they call it, warmed up blankets, they'll be using it. Along with it, you can also use warmed IV fluids. We'll be talking more about hypothermia in next coming up classes. In environmental class, we'll be talking about more about hypothermia. If it is an hyperkalemia, I didn't talk about hyperkalemia management. Hyperkalemia management is important. First thing, first drug, what you need to give it is calcium. You need to supplement with the calcium. Either you can give it calcium chloride or calcium gluconate. It doesn't mean one is superior than the other one. Just that calcium chloride 10 ml, 10% over 2 to 5 minutes. The quantity what is required is less compared to calcium gluconate. So you can give it a little bit easier compared to that of the calcium gluconate. For that particular reason, if at all, if you're forced to choose calcium chloride over calcium gluconate, but none of the studies have shown that calcium chloride or calcium gluconate is superior to each other. Next, you will be doing the insulin dextrose infusion. So this is always step one. Calcium therapy is always step one because it will help to stabilize the cardiac activity and help to stabilize the electrical activity, what is happening in the heart. That will, for example, if the patient is having VT, it will help to revert back to the sinus rhythm. That will help you to achieve the ROSC. Next, insulin dextrose infusion, you'll be using 10 units of short-acting insulin. Usually use short-acting insulin is human actrapid, mixed with 50 ml of 50% dextrose and given over 15 minutes. Next one is sodium bicarbonate. So any patient in cardiac arrest, we tend to give sodium bicarbonate. Okay, if he's not in cardiac arrest, then we'll see whether there is an acidosis which is present, then we give sodium bicarbonate. 50 millimoles IV you will be giving. This 50 millimoles is nothing but 50 ml of 8.4% solution. You got and DROSC, but still the potassium levels are on the higher side. For example, initially it was 8, it has just come down to 7.5 and you are able to achieve the ROSC. In spite of medical therapy, if the potassium levels remains quite high, then you might have to do an dialysis. Dialysis is not impossible, but practically you can say it is impossible to get a dialysis done while ongoing CPR because it needs a dialysis catheter. If the patient already has a fistula, then you can try to do with an ongoing dialysis in that patient and try to reverse it. Now we are going to 4 T's. One of the T's is tamponade. Tamponade, how do you find out it is a tamponade? Tamponade has a classical signs which they will present with. There will be enraged JVP, that is distended neck vessels will be present. Okay. And muffled heart sounds, you can't hear it. That's the problem. Okay. Other than raised JVP, you can't hear. Hypotension, you don't have a blood pressure recording at all in a cardiac arrest. You can't know what is blood pressure is. Muffled heart sounds, the heart is not beating because it is in cardiac arrest. You cannot make out. Only the raised JVP itself has two differential diagnoses. In a cardiac arrest scenario, it can be a cardiac tamponade or it can be an pneumothorax. That's when a focused ultrasound will be definitely helpful. Ultrasound, you do it and you find out there is a free fluid. The black color what you're seeing around the heart is suggestive of a free fluid around the heart. If that is present, then yes, it is an cardiac tamponade. In a cardiac arrest scenario, you will be doing an clamshell thoracotomy. This is known as clamshell thoracotomy. It might be because of toxins. Toxins is difficult unless you have a collateral history available or you're taking an history suddenly collapse. At that point of time, you can guess it out. It might be because of some toxin. For example, there is a good history that he has taken a beta blocker overdose and he has arrested. Then you can use a glucagon reversal agent. Sometimes if you have a lot of needle marks which is present and pupil is pinpoint, then you are thinking it might be an opioid overdose. So you need to look out for the clues to make out, okay, it is a toxin, and you use the reversal agent if reversal agent is present for that particular toxin. Thrombus. Thrombus, if it is in pulmonary, look for any signs which are present of TVT or unilateral leg swelling if it's present. Okay, it might be an PE in that scenario. Ultrasound will be definitely helpful. You will be seeing for an RV, that is right atrial and right ventricular dilatation. The sign D, which we talked about in our cardiology class, we'll be looking out for that while doing the focused cardiac ultrasound. What about coronary thrombus? Coronary thrombus, solely you need to depend on the history. The patient had an classical chest pain and collapse. You're thinking of an coronary thrombus in that. Just before the collapsing, you had gotten 12-lead ECG done. It shows an STEMI. Yes, you have the diagnosis there. So in that way, you need to depend coronary thrombus. Mainly, you need to depend on the history itself. If an ECG is done just prior to it, which is suggestive of an MI, then you can easily intervene and think of an coronary thrombus. Coronary thrombus is nothing but you're thinking about myocardial infarction. Once you think, yes, it is an thrombus what this patient is having, then you will be using an thrombolytic agent. Okay, you're trying to break the thrombus what is present. Especially for PE, we tend to use tenecteplase because it can be given as an push, a bolus. If that is not available, alteplase can be given, but it takes time to be given. You can see it has to be infused over 30 minutes. You need not remember the dosing. There will be a preset protocol. You will be following the preset protocol. This is for pulmonary thrombus. What about coronary thrombus? If you're suspecting a coronary thrombus and you're confident about that coronary thrombus, the ideal way to treat this patient who is in cardiac arrest is with ongoing CPR, shift this patient to the cath lab and get an angiography and angioplasty done. If you open the block in the cath lab, chances of this patient reverting back will be much higher than using a thrombolytic agent. If you do not have the cath lab readily available at that point of time, then you might consider make a team decision to give an thrombolytic agent. Tension pneumothorax. I told you, a RICE JVP has a two differential diagnosis, a cardiac tamponade or a tension pneumothorax. Use the same ultrasound to differentiate it. You're not seeing any free fluid. Do I see an barcode sign? Okay, we'll be studying about more about this barcode sign in the next major trauma class. So do not worry about this is supposed to be an barcode sign. Presence of this barcode sign, what you need to do, it's a tension pneumothorax. There are other signs also what you can pick it up. When you're giving rescue breath, the air entry will be reduced on that side. When you percuss it, it will be hyperresonant on that side. Okay. And the trachea might be deviated to the opposite side. Again, we'll be studying more about tension pneumothorax. Do not worry, in the major trauma, I'm briefly touching about. You need to immediately decompress it and followed by insertion of an chest drain. Decompression sites are important. Remember now itself, if it's an adult, it is just anterior to the mid-axillary line, fifth intercostal space. Here, what you're doing a needle decompression. If it's a child, it is a mid-clavicular line, second intercostal space, what you're doing it. Preferred one is to do an finger thoracotomy, especially in trauma case. If it is a tension pneumothorax, finger thoracotomy is much more preferred than doing a needle decompression. I'll be talking about in coming up slides. Special situations in cardiac arrest. Someone who is pregnant. We are really worried if someone who is more than 20 weeks of gestation. Okay, if someone is more than 20 weeks of gestation, we are really worried because this fetus can be saved. One is fetus, what is present, can be saved. Okay, if it is less than 20 weeks, we are not that worried about the fetus because even if you deliver the baby immediately by doing a C-section, that fetus cannot survive in the external environment because it is too young to survive in the external environment. It has to be at least 20 or more than 20 weeks of gestation. Another thing is, if the gestational age is more than 20 weeks, it causes compression over the inferior vena cava. Because it causes compression over the inferior vena cava, the preload will be reduced. If the preload is reduced, you may not be able to achieve the ROSC. Keeping this in mind, they have come up with the guidelines, what needs to be done if someone is pregnant. The thing what you need to do is someone who is pregnant and more than 20 weeks of gestation, get an cesarean section done within 5 minutes of the cardiac arrest. Within 5 minutes, you need to do it. This is in hospital, what we are talking, not outside hospital, where you'll not even have the equipments to do an C-section. In hospital, you have an cardiac arrest and it's been 5 minutes, there is no ROS, then you immediately deliver. So whenever you get an pre-alert that there is a pregnant lady coming to the emergency department in a cardiac arrest, make sure you have the gynecology team available there in emergency department, scrubbed up and ready to do a C-section. Next thing, what you need to remember, compression on the IVC. Compression on the IVC, that is inferior vena cava, is placed towards the right side of the vertebrae body. So the patient needs to be tilted towards the left side. So the left lateral position, the patient should be there. This will cause decompression over the inferior vena cava. The other method is pushing the fetus towards the left side. So the pressure over the inferior vena cava is reduced and the venous return increases, the preload increases, and you might be able to achieve the ROSC in these individuals. These are the two main changes in obstetric cardiac arrest. That is, anyone who is pregnant when more than 20 weeks of gestation, you need to think of. Additional things, what you need to remember, hand position, it remains the same. There is no changes at all. If the patient was in eclampsia, for example, it was seizing, the patient more than 20 weeks of gestation, came in with active seizures, then went into cardiac arrest. You magnesium immediately at that point of time. What about placing the defibrillator pads? Place it as much as possible in the same anatomical landmarks that we'll be discussing in coming up slides. Do not change it. The shock of energy also remains the same. We are not using it. So standard as much as possible, little bit up or down, you might have to place it because of the engorged breast due to the pregnancy might be present. So little bit changes, but as much as possible in same anatomical position, you will placing it. If you haven't skilled labor, try to place an endotracheal tube as soon as possible because the gravity uterus itself will be causing compression over the will be causing compression or pushing the diaphragm upwards. So the respiration might not be adequate and hypoxia might be one of the causes for the cardiac arrest. A fast scan, what you'll be doing, the ultrasound scan, the POCUS, the point of care ultrasound scan, what you're doing, use the same ultrasound scan to check for the fetal heart rate also. What are the specific causes? Specific causes, it might be in PE, which is very commonly seen in pregnancy because of the predisposing factors. Pregnancy itself predisposes them for the thrombus formation. It might be an amniotic fluid emboli. It might be an MS. This MS we have already dealt with it. They present with an heart failure, which we have dealt in the cardiac chapter. MS stands for mitral stenosis. Hypovolemia. Hypovolemia because of abruptio placenta or placenta previa or uterine rupture or uterine atony, what we are talking about. Okay, this is not because of any miscarriage. Miscarriages happens during first trimester or early part of the second trimester. That will never cause enough blood loss to go into an cardiac arrest. So always think of hemorrhagic cause in later part of the second trimester or early in the third trimester. That will be mainly because of abruptio placenta or placenta previa or ruptured uterus or an uterine atony. Cardiac tamponade also might be present. This is mainly because of peripartum cardiomyopathy. Thrombus, again, we have discussed, is the PE itself. PE can cause hypoxia and it is a thrombus also. Toxins, some local anesthetics you are given. For example, you want to do an episiotomy and you're given local anesthetic infiltration, not calculated, overdose, arrested. Magnesium, this patient was pre-eclampsia, you are overdosed with magnesium, can arrest. Next special circumstance what we are dealing is hypothermia. There is a classification known as Swiss stage classification, which we'll be learning again in our environmental chapter. So remember that whenever the core body temperature is very low, we are talking about in 28 or less than 24, the patient will go into cardiac arrest. That low core body temperature should be there for the patient to go into the cardiac arrest. Most of the time, it will be very low temperature. There are multiple changes to the standard ALS algorithm. This is the table form, what you need to remember. It is very, very, very important. I'm stressing it a lot because every diet, there is one question which appears from this table, what I mentioned here. So make it sure you know in and out of this table. Whenever I wake you up from the sleep also, you should be able to tell what are the ALS changes there in hypothermia. First three shocks, it is a shockable rhythm. First three shocks, you can give it at any core body temperature, doesn't matter. But when you're giving the fourth shock for unshockable rhythm, that is after 3 shocks, make sure the core body temperature is more than 30 degrees Celsius. If it is less than 30 degrees Celsius, you are not giving the fourth shock. You're waiting till the core body temperature increases to more than 30 degrees Celsius. More than 30 degrees Celsius, that means it should be 30.1 at least. Then only you are, sorry, then only you are giving a shock. If it is 30 degrees Celsius, also you are not giving the shock. Don't give adrenaline if the core body temperature is less than 30 degrees Celsius. Once it is 30 degrees Celsius, you give the first dose of adrenaline. But for the second dose of adrenaline, the duration is double, 6 to 10 minutes till the core body temperature is more than 34 degrees Celsius. Once the core body temperature is more than 34 degrees Celsius, then you start giving it every 3 to 5 minutes. Every 3 to 5 minutes, that is a regular thing what we are doing it, what we have learned previously in previous slides, is the same thing. But this is the double the duration what you're giving. Here, when the core body temperature is between 30 to 34 degrees Celsius. If it is less than 30 degrees Celsius, we are not giving at all. So each point of this has been previously tested. So it is very important. A question will definitely appear in the exam from this tabular form, what I'm expecting. Few more things what you need to remember is if your plan to stop the CPR, make sure you check for the carotid pulse for at least a minute's time. 1 minute at least you need to check for. Why you need to check minimum of 1 minute? Because of a hypothermia, you may not be able to feel the pulse as you feel in a normal human being who is not hypothermic. For that reason, at least check for 1 minute. Bradycardia might be present in the patient. Okay, you achieved the ROSC. Before you achieve a ROSC, we do not call it brady or tachycardia. Once you achieve a ROSC, bradycardia you will be having. I'm assuming there is a bradycardia. Okay, we are assuming patient is having a bradycardia. We assume this bradycardia is because of hypothermia. Okay, so increase the core body temperature. Once the core body temperature is more than 35 degrees Celsius, still the patient is having a low heart rate, plus there is a life-threatening future. For example, there is a hypotension is present. At that point of time, what you'll be doing, the patient is in heart failure. At that point of time, you'll be following the bradycardia algorithm and treating it. Otherwise, you are not treating for the bradycardia. The likely cause for bradycardia is hypothermia. So just increase the core body temperature. The bradycardia is still there and the patient is having life-threatening future in spite of increasing the core body temperature for more than 35 degrees Celsius. That's when you'll start intervening by following ALS algorithm for bradycardia. Asthma. Asthma is a respiratory disorder. So hypoxia is one of the leading causes for cardiac arrest in asthma. Hypoxia itself can cause irregular rhythms, so cardiac arrhythmias can lead to an cardiac arrest. These patients, whenever they go in cardiac arrest, asthmatic patient, we need to always think of bilateral tension pneumothorax should be in your mind. It can be a bilateral thing. So you cannot compare one side with the another side. It's a bilateral air entry is reduced. Bilateral hyperresonance is present, which is very commonly seen in an asthmatic patient. There is a special thing what I'm talking about. This is known as dynamic hyperinflation. If you remember, asthma is an obstructive airway disease. Okay, it's an obstructive airway disease, not a restrictive airway disease. It's an obstructive airway disease, what we call it. So what does it, I'm sorry. So what does it do? So it is a lung what is having. Okay, if this is a lung, it will allow the air to enter in. So inspiration wise, it will allow the air to enter in, but it will not allow the air to go out during expiration. It gets obstructed here in the lungs itself. If you are giving with a high tidal volume, that means with a lot of pressure, you're pushing a lot of air inside the lungs. It can get entrapped here. That is known as dynamic hyperinflation. It is also known as gas trapping. This usually doesn't occur with the back mass ventilation, what you're doing, and with the chest rise, what you're seeing in a cardiac arrest. It doesn't happen. Usually this happens if you're intubated the patient and you start doing back mass ventilation and suddenly you're giving a lot of tidal volume. That means you're pushing in a lot of air at that point of time. Dynamic hyperinflation can happen. At that point of time, what you do is you disconnect. What you are disconnecting? You're disconnecting your ambu bag from the ET tube and apply the external pressure for the chest. This is the chest. Apply the external pressure, compress it so that all the air comes out. then continue the cardiac arrest. This is known as dynamic hyperinflation. Another thing what you need to remember is, as this is an obstructive airway disease, air gets trapped inside the lungs. If the air gets trapped inside the lungs, it is a bad conductor of electricity. Because air is getting entrapped into the lungs and it is a bad conductor of electricity, the shock will not be delivered adequately to the heart. So we usually use high energies to shock the patient. And this question has been multiple times asked previously, and previous that also they have repeated the same question. So remember, in asthma patient, as it is an airway device, as this is an obstructive airway disease, the air what you're ventilating might go into your stomach and cause inflation. So try to intubate the patient as soon as possible. Okay, dynamic hyperinflation, I have already explained you. Increased transthoracic impedance, nothing but it is an increase in resistance. You need to use high energies to shock this patient. Usually we use 150 joules in a cardiac arrest. Here you might have to use 180 or up to 200 joules. Also, you might have to use an increased energy might have to be used here in these circumstances. Tension pneumothorax, bilateral finger thoracotomy is the preferred one, followed by, if that is not available or you're not skilled enough to do it, needle decompression, followed by you need to place an ICD. ICD stands for intercostal drain, ICD. Traumatic cardiac arrest. All right. What is traumatic cardiac arrest? A trauma, the patient had a trauma. It can be a road traffic accident. He has fallen down from a second floor of a building. It might be any trauma, injury has caused. Has this is an traumatic cardiac arrest or no? For example, he had a chest pain, he has fallen down and he has collapsed. That may not be a traumatic cause. It means most likely chest pain is because of an coronary thrombus. That's why he had gone into cardiac arrest. Then you will be following the ALS algorithm. No, you're not thinking about the medical cause itself. It's in trauma. It was a road traffic accident. He's smashed by another car. That's why he is in cardiac arrest. At that point of time, this algorithm what you need to follow, not the previous ALS algorithm what we have followed. There are different reversible causes. Mainly 4 reversible causes are present. Most of the time, it is the hypovolemia, hemorrhagic shock, which has caused. It can be an hypoxia, anything which obstructs the upper airway. It might be there because of low GCS. It might be hypoxia. A tension pneumothorax, a cardiac tamponade. These are the 4 main reversible causes for any patient with a traumatic cardiac arrest. As usual, what we learned previously, you will immediately start on the CPR. Okay, once you immediately start on the CPR, then you will be addressing one by one in the same sequential order how I have mentioned. This is the first one, this is the second, third, fourth, fifth, sixth, and seventh. The first thing what you'll be doing is control external catastrophic hemorrhages. There is an obvious spurting of the blood is seen from the thigh. Deal with it. Stop the bleeding where it is bleeding from. Then what you'll be doing, you'll be going first for the airway. In airway, you will try to secure the airway if possible. If you have the skills, secure the airway, give high flow oxygen, connect to the mechanical ventilator, or continue with the bag mask ventilation. Still, the patient has not improved, still in the cardiac arrest itself. Then you'll be going for the breathing and doing a bilateral chest decompression. This is known as bilateral chest decompression, also known as finger thoracotomy. What is finger thoracotomy? It is nothing hi-fi procedure. It's similar to placing an ICD. Just anterior to the mid axillary line, you will make a incision which is kind of parallel to the 6th intercostal space. In the 5th intercostal, parallel to the 6th rib in the 5th intercostal space, you will be making it. Then you will be doing a blunt dissection till you open up the parietal pleura. Once you open up the parietal pleura, you are in the pleural space. If it is an hemothorax or pneumohemothorax, it will start draining. You will be doing on bilateral side. Both sides you have done it. That's why it is known as bilateral finger thoracotomy, also known as chest decompression. Still not improved. If still not improved, at this point of time, we are thinking it might be an tamponade. Okay. Especially you need to think of this if there is an chest injury is present. Or it might be an continuous vascular bleed that is in circulation. We're thinking about it is in proximal vascular bleed. What we're thinking about, somewhere he's bleeding in the chest, it might be. So you need to open up the chest and see where is he bleeding from, or he might be bleeding from the abdomen. At this point of time, what you'll be doing? they recommend you to do an thoracotomy. But you need to first question yourself, do we have an expertise to do an thoracotomy? Are you trained to do an resuscitative thoracotomy? Yes, then go ahead and do it. Do you have the equipment to do an resuscitative thoracotomy? That also should be present. Yes, then good. Along with it, you need to do what is the time since this patient has been collapsed. That means the patient has been in cardiac arrest. If it is less than 15 minutes in penetrating trauma and less than 10 minutes in a blunt trauma. So you have an expertise, you have all the equipments, and the duration is only less than 15 minutes in a penetrating trauma and less than 10 minutes in a blunt trauma, then you are going ahead with a resuscitative thoracotomy. Otherwise, you cannot do or you shouldn't do an resuscitative thoracotomy. If you do not have equipment, how you will do it? If you are not expertise, then do not do it. If the time has already collapsed, then also it is not an indication to do it. Do not do it. Remember this thing's important. This is also important. That's when you do it. And remember that thoracotomy doesn't come immediately. First, you're controlling the external catastrophic hemorrhage, then securing the airway, then you're doing bilateral finger thoracotomy, then only you're thinking about an then only you're thinking about a resuscitative thoracotomy. This is resuscitative thoracotomy, clamshell thoracotomy. You're entirely opening up the chest and looking inside the chest what is happening. Two things you can correct it at this point of time. It's a cardiac tamponade. You can easily drain it and fix it. There might be a major artery which is bleeding in the chest. Then you can just fix that major artery which is bleeding, which has caused the cardiac arrest. Along with it, no, nothing is wrong in the chest. You open up the chest, nothing is wrong in the chest. That might be one of the possibilities which might be happening. Okay, at that point of time, you need to start thinking about Ribova. Okay, or you're sure that the bleeding is there in the abdomen or the pelvis, you can do an Ribova. I'll get back to it. Once, no, it is not, nothing wrong in the chest, nothing wrong in the abdomen, look at the pelvis. If pelvis instability, that is a pelvic fracture causing the cardiac arrest, then place an pelvic splint. And in the C itself, you need to activate and major hemorrhage protocol, start infusing the blood. Okay, according to the major hemorrhagic protocol. If you achieve the ROS by doing these interventions, then what you'll be doing might require a surgery. If it is an abdominal injury, might require a surgery. If it's a chest injury, especially penetrating, might require an intervention by an cardiothoracic surgeons. Involve them specifically. If no, if you have done everything, still ROSC is not acute, then you might have to unfortunately think about stopping or terminating the resuscitation. All right. Now, few things which usually if you go and ask most of the practicing doctors in the emergency department may not be aware of this. They kind of still end up following an ALS algorithm. No, ALS algorithm shouldn't be followed. There are few things which are quite different from the ALS. Things what are? You started CPR as soon as you know the patient is in cardiac arrest. But at any point of time, you feel you need to stop doing CPR because you're not able to intervene. For example, for doing a thoracotomy, you need to stop doing an CPR. You cannot do it because you need to put an incision and place and clamp and open the chest. You cannot do it. At that point of time, you stop the CPR. That's why it is written importance to treat the underlying cause needs to be given rather than to the CPR. CPR, you'll start any patient who is in cardiac arrest. But at any point of time, you feel CPR is stopping me to intervene in this patient, stop the CPR and intervene. There's no point in continuing CPR if you are not able to intervene and treat the cause which has caused the cardiac arrest. That is completely different from ALS, where we say do not stop the CPR. If you're stopping, also make sure it is not less than 5 minutes, which is completely different in a trauma case. This is according to the European Resuscitation Council 2021 guidelines, what we are talking about. Next thing is thoracotomy. I said thoracotomy to be done. How an thoracotomy is done? Have a brief idea about thoracotomy. I'm briefly talking about the thoracotomy here. What we are doing is there is fifth intercostal space you're done and bilateral finger thoracotomy. That is fifth intercostal space on both sides, just anterior to the mid-axillary line. You have placed an insertion and blunt dissected up to the level of pleural space. Same thing connected with an incision, which is running in the fifth, between the fifth and the fourth or the fifth and the sixth rib. Just connect the both sides, make an incision. We usually make an incision by using a scissors. You're cutting the intercostal muscles. Once you cut the intercostal muscles, then you are using a clamp and you separate it. Okay, basically you're lifting up the entire thoracic cage by lifting like this. Then you are visualizing what is wrong. It looks like an clamp shell. What you find it usually a pearl inside the shell. So you're using a clamshell to open it, and you can directly visualize it and intervene accordingly. REBOA I was talking about. REBOA is a full form for resuscitative endovascular balloon occlusion of aorta. This is known as REBOA. REBOA is an latest thing. Have not yet been tested in the exam. I'm suspecting they will be testing you in, if not your dad, some dad, they have to test you because this is a new thing. It is extensively used in trauma. Okay, in trauma centers, especially in NHS, they are using it a lot. There is a simple logic here. There is some bleed happening. What you'll do? Occlude the aorta above that level. Occluding the aorta above that level, there will be no loss of the blood. So you will achieve an ROS. Once you achieve a ROS, immediately shift to the operation theater and just see where he is in bleeding and involve the vascular surgeons. They will rectify it. That's the idea behind it. So what they will be doing in, I'm sorry. So what they will be doing in REBOA? In REBOA, first what you'll be seeing is the patient hypertensive. Okay, or the patient is in cardiac arrest. One of these things. Okay, I'm talking about non-cardiac arrest hypertension, or the patient is in cardiac arrest who is not responding to the interventions what we talked about previously. At that point of time, get a chest X-ray done to see whether there is an aortic injury or not, bedside chest X-ray. If yes, then you cannot do it because this is the arch of aorta and going. You cannot occlude it here if the bleeding is somewhere from here. If you occlude it here, he will bleed extensively from here and die. So it is a contraindication. If you're vaguely suspecting an aortic disruption, there any injury to the aorta, that is the arch of the aorta, thoracic aorta I'm talking about, then you are not doing REBOA. That is a contraindication. No, it is not the case. Then you will be checking, is the fast scan positive? Positive for FOD, free fluid. You can see free fluid on the FOD scan. If you see a free fluid on the FOD scan, that means bleeding is somewhere in the abdomen from an abdominal artery. So you need to block the aorta above the level of diaphragm. That is zone 1. As shown here, you will be inflating the bulb in zone 1. No, fast is negative. Then you'll be seeing, is there any pelvic fracture on a pelvic X-ray or there is any instability is present? Yes, it is present. Then what? Sorry, this is not yes, this is no. Sorry. Yeah. Yes, there is a pelvic fracture present. Then you will be inflating the bulb in zone 3. Why in zone 3? Why not in zone 1 or zone 2? The main reason is if you occlude it in zone 1, the blood, there will be compromise of blood supply to the zone 1 or 2. It holds good. There will be compromise in the blood supply to the abdominal organs. Okay, you do not want to risk the abdominal organs going into ischemia and infarction. For example, bowel, there is a spleen, there are kidneys, they might all fail together. It is not required because the bleeding is not in the abdominal artery. It is bleeding is somewhere in the pelvis or below the pelvic level. It is bleeding. So you can just above the bifurcation of the aorta, inflate the bulb and stop the bleeding and save all the abdominal organs. That's why you're inflating in the zone 3, what has been shown in the picture. If there is no pelvic fracture, the patient remains hypertensive or not improving, then again you will inflate it in zone 1. This is known as REBOA, resuscitative endovascular balloon occlusion of aorta. Again, traumatic causes, we have already dealt with it, most of it, hypoxia. Again, you can do an endotracheal intubation or place in supraglottic airway device. Hypovolemia, compressible hypovolemia. This is important. Remember that. Apply direct pressure by doing a normal dressing. No, not happening. Then you are doing a pressure dressing. Pressure dressing is different from a normal dressing. For example, this is a wound over a limb what you are having. In a pressure dressing, what you'll be doing is you're taking and rolled up cotton gauze like this. Place it over the wound like this. Then take a roller bandage and roll it across. So the maximum pressure will be on the wound what is present. That will help to stop. If that doesn't stop, you will be using a tourniquet proximal to it. If that doesn't stop, you will be applying one more tourniquet more proximal to it. That should stop it. There are novel hypostatic agents, free dressings. You place it in the wound, it expands. Yes, that can also be used. Major hemorrhage protocol needs to be activated as soon as possible because these patients are in cardiac arrest. There might be non-compressible hemorrhages. For example, if the hemorrhage is in the abdominal cavity, it is an non-compressible, you're not visualizing it at that point of time. What you'll be doing is just activate major hemorrhage protocol. Till the blood products are available, you will be giving intravenous fluid. What do by splints? When the splint will be used? Remember that because of an femur fracture, no other bone, only femur. Okay, because of an femur fracture, there might be enough blood loss to cause hemodynamic compromise and the patient goes in the cardiac arrest. So whenever there is an femur fracture is present, apply and splint. What splint we apply? Thomas splint we apply. Apply this splint. Once it comes into an anatomical position, the bleeding usually stops. For that reason, splint what I have written there. Tension pneumothorax, we already know how to deal with tension pneumothorax. That first we'll be doing bilateral finger thoracotomy. Needle thoracotomy is not preferred in trauma cases. Once bilateral finger thoracotomy is done, or finger thoracotomy is done, then you'll be placing a chest tube. Cardiac tamponade, in a cardiac arrest scenario, you will be doing thoracotomy. But again, as I told you, all these three things needs to be satisfied for a thoracotomy. You're not able to do a thoracotomy. At that point of time, you can try doing pericardiocentesis as an interim measure. Thoracotomy is the best one. If you're not able to do a resuscitative thoracotomy, then you're doing an pericardiocentesis. The procedure we'll be learning in the procedure chapter. What about drowning? What special things, what do you need to do with drowning? Whenever the patient is drowned, chances of pooling of the blood in the veins will be much high. So you need to pick up the patient in an horizontal position, not pull him out of the water body in a vertical position. Horizontal, in this position, he needs to be picked up. All right. You shouldn't be in the vertical position in this manner. You should be in the horizontal position. What do you need to pick it up? Most of the time, the cause for the cardiac arrest is hypoxia. Because of hypoxia, there is change in the normal BLS, what we do. In normal BLS in adult, what we do, we start with chest compressions. Here they say give 5 rescue breaths first. After that, reassess and see whether you are acute ROSC or not. If you're not acute ROSC, then continue with the normal BLS algorithm. So this is a new thing what you need to remember. If they are immersed for a long time, more than 10, 15, 20 minutes, hypovolemia might be one of the causes for the cardiac arrest. IV fluids will be giving. Again, nothing drastic changes. So the two important changes is 5 rescue breaths in the BLS. First initiating, not the chest compression, 5 initial rescue breaths needs to be given. While you're pulling out this patient from an water body, make sure you're pulling out him in an horizontal position rather than in a vertical position. Special consideration of a prolonged CPR, when to continue for a very long time. We call it as a prolonged CPR if you're continuing for more than 40 minutes. When do you call it as a prolonged CPR? When you need to really continue for a very long time? Hypothermia. Okay, you do not label a patient a dead till you warm the patient. Okay, so a cold patient is not dead till you warm the patient. Then only you can say, yes, I am not able to achieve the ROSC and this patient is dead. In asthma, till you correct the dynamic hyperinflation, you continue with the CPR. In toxicology arrest, studies have shown that as long as 4 hours, if you do an CPR, still you can achieve the ROSC. Few cases are there. They have shown that more than 4 hours we have done the CPR and we achieve the ROSC, which may not be practically possible in most of the centers, but plan to do a long CPR if you're thinking it is an toxin which has caused the cardiac arrest. If you are used in thrombolytic while ongoing CPR, give the time for the thrombolytic to act. For example, it is a PE, you are given an tenecteplase. Give him at least 2 hours for the thrombolytic to act. You immediately give it, you continue it for 10, 15 minutes, you stop the CPR. There is no point. Why did you give the thrombolytic? It has not even acted. And what are you expecting? That questions will arise. You just wasted the resources. You shouldn't be wasting the resources. If you are using thrombolytic, continue for 2 hours. If it is a pregnancy, till C-section you have done and deliver the fetus and you treated all the reversible causes, still you're not, then only you call it an death patient. So you need to continue for a very long time. If it's a young patient, young in the sense anyone less than 50 years also we call it young. Or anyone who is having an shockable rhythm, VF or VT, persistent VF and VT this patient is having, continue doing the CPR till he has a shockable rhythm. Once this shockable rhythm converts into an asystole, that is non-shockable rhythm, then you can think of stopping the CPR. Continue for more than 40 minutes. That's what is recommended. Sometimes you might have to stop the CPR. It's not that always you get an ROS, that is return of spontaneous circulation. Sometimes you might have to stop it. When to stop it? What you need to consider while stopping it? Remember that when you need to stop, it is a team decision what needs to be done. So all the team members who are there need to agree with you to stop the resuscitation. The parameters what you need to look out for is duration. Usually we look out for is more than 20 minutes of CPR. At least 20 minutes of CPR we have done. No response to the intervention. That means you have intervened for all the 4 Hs and 4Ts. You've gone through all the reversible causes, the 4 Hs and 4Ts, what you have learned so far, and you have intervened accordingly, but still you have not achieved the ROSC. On an ETCO2, there is a persistent low reading what is seen. This is the low reading what you are having, a low reading on the ETCO2 monitor. On an bedside ultrasound scan, there are literally no cardiac movements. Heart is still. Myocardial muscle is completely still. Okay, these are the parameters what you'll be considering. Doesn't mean one parameter is superior than the other parameter. We usually see at least 2 parameters are present to call it and stop to the resuscitation. For example, it is more than 40 minutes or more than 20 minutes and it is cardiac standstill on the ultrasound. I have done all the reversible causes and it is cardiac standstill on the ultrasound. So you have any two of this, any combination you have, you can stop the CPR. In exam, by any chance, they have given all this as one of the choices, 1, 2, 3, 4. Then what to do? At that point of time, I recommend you to choose an cardiac standstill on ultrasound, because if it's a cardiac standstill on an ultrasound, the chances of this patient not getting a ROSC is almost close to 100%. Okay, if it's a cardiac standstill on an ultrasound, unlikely you gonna achieve a return of spontaneous circulation. Now you have declared, now you have stopped the CPR. Have you declared it? No. You need to confirm the death. How do you confirm the death? For minimum of 5 minutes, what you'll be doing in this 5 minutes, okay, 5 minutes duration after stopping the CPR, check for the central pulse. At least for a couple of minutes, check for the central pulse. No central pulse is present. Check for the heart sounds. So you're auscultating with your stethoscope at least for 2 minutes. No heart sounds are present. Look for at the same point, look for any respiratory sounds are there. You need not check for 2 minutes. You're just looking in 30 to 40 seconds, any respiratory efforts are there and any auscultatory sounds are present. Okay. At the same point of time, look for any movements of the hands, any chest raise is present. None of this following is present for the 5 minutes. Then you will be checking for the pupillary reflex. That is basically you're flashing the light over the eyes to see whether there is constriction of the pupils. Light reflex, what you're saying. Absence of that should be present. Absence of corneal reflex. So you'll be just striking with an cotton or wool basically, and the sclera of the eye, you'll be just striking it with the wool and see whether there will be closure of the eyelids. If not, that means absence of corneal reflex should be present. Absence of motor response to a painful stimulus to the supraorbit of your supraorbit supraorbital pressure when you applied. At that point of time, if you're not, there are no movements at all. There is no motor response at all. That means no hands or no limbs are moving at all. Then also, that also should be present. If all these three are present, then you will declare the death. While declaring the death, make sure you confirm the patient identity. Okay, this is the same patient what we are having, patient identity. What time you will be recording? Once you're completed this much, everything is completed. At that time, you will be recording the time. It's not the time when you stop the CPR. It's the time when you checked 5 minutes for all these efforts. Then you have done all this. After that, what is the time you'll be seeing in the clock? And that one you will be recording it. This is the post-cardiac arrest algorithm. Congratulations, you have achieved the ROS, what needs to be done. I will stop here and go through the doubts if you guys are having accordingly. Then we will be entering into the post-cardiac arrest algorithm. To do compressor, IVC, manually pushing the fetus towards the right or towards the left side. From the right side, you need to push it towards the left side. As you're seeing here in the picture, as you see in the picture, this is the right side, this is the left side. From the right side, you're pushing towards the left side because the IVC comes at the right side. Vasopressors in hypothermia, we do not use vasopressors at all. If you're talking about adrenaline, then there are ALS changes what we have spoken about. I'm not sure which vasopressor you are talking about. We are not using any other drugs. These are the drugs what I have spoken about, and you will be continuing with the similar drugs. Okay, in any cardiac arrest, normal cardiac arrest also, other than adrenaline, you're not using a dopamine or dobutamine or digoxin or isoprenaline. You're not using that kind of drugs at all. So those were the two questions. So we'll be continuing with the post-cardiac arrest algorithm. So here, acute adrenaline hypothermia, we have already explained there is an algorithm, there is a tabular form. We can go ahead. Already explained extensively, actually. Okay, post-cardiac arrest algorithm, we are entering it into. Okay, so you are assessing the patient. Once you have got an ROSC, that doesn't mean you stop it there. You need to do an post-cardiac arrest care, which will be starting with an airway. Okay, first in airway, you need to make sure the airway is secured. Unless rarely the GCS will be good enough to maintain the patency of the airway. Most of the time, you will require an endotracheal intubation. So intubate the patient if it is not already been intubated. Confirm the intubation by ETCO2 monitoring. Then get a chest X-ray to make sure the position of the trachea. Okay. At the same chest X-ray you are done. This will take care of the breathing also. So both goes hand in hand what we are dealt here. Then coming to the circulation, you will be getting a 12-lead ECG done, which is very important. Make sure you have an IV access. If you are not have an IV access by now, make sure it have a good IV access. And you need to aim for a systolic blood pressure of more than 100. For this, if the cause is hypovolemia, there is low blood, there is less of intravascular volume is present, then you will be resuscitating with giving more fluids. Okay. Or you might have to give the blood products in an hemorrhagic shock. No, there is enough intravascular volume is present, which you can see it by visualizing the IVC and looking for the compressibility on an ultrasound scan. Then you will be starting on the inotropes. Okay, so your target is to maintain the systolic blood pressure more than 90 in circulation. What about core temperature? Core temperature, yes, therapeutic hypothermia needs to be done, needs to be maintained around 32 to 36 degrees Celsius. But this cannot be done in the emergency department. It is difficult to do it in the emergency department. Usually it is done in an ICU setup, intensive care unit, where they will be doing it. It requires a special kind of thermometer, which is inserted like an NG tube into the stomach, which gives you the reading. Goes goes through your esophagus into the stomach like an NG tube. You will be inserting it. Okay. If while you're having a therapeutic hypothermia, then you might have to sedate him to stop the shivering. So remember this reading, it might be tested in the exam. 32 to 36 degrees Celsius is the therapeutic hypothermia, what you're doing it. Ask yourself, is this a cardiac cause? Yes, this patient had a chest pain before he collapsed. Yes, it might be a cardiac cause. So you are getting an ST segment elevation, 12 DCG you already have in circulation, you got it done. Is there an ST segment elevation is present? Yes, immediately shift to the cath lab, involve the cardiologist. No, it is not present. Just consult with the cardiologist and tell him or explain him why you think it might be still an cardiac cause. If he agrees, he'll take up for angiography. If he doesn't agree, then he'll take up look for any other causes. Unlikely this to be an cardiac cause. Okay. At that point of time, what you'll be doing? At that point of time, if you're not able to make out the cause for the cardiac arrest, then get NCT brain, NCT PA, accordingly intervene in the ICU. That is intensive care unit. What happens in ICU is not out of interest of emergency physician. So this part is not required. You need not remove it. As mentioned here, therapeutic hypothermia, they will be doing it there. It is more for the ICU. It's not for us. So you need not remember it. You can skip this slide. Now we are entering into tachycardias and bradycardias. Okay, tachycardias and bradycardias, one common thing I'll be repeating multiple times is life-threatening feature. What is life-threatening feature? You need to be aware of. So anyone who comes with a tachyarrhythmia, or an bradyarrhythmia, first thing you will be seeing whether there is a life-threatening feature. So in exam, what you'll be seeing in the stem of the question, have they mentioned any life-threatening feature for the tachyarrhythmia or the bradyarrhythmia the patient has presented with? In a real life, you will be trying to gather the information to see whether there is any life-threatening feature which might be present in this individual. So there are 4 life-threatening features. One is shock, syncope, severe heart failure, myocardial infarction. Let's break down each one of this. Shock. How do you see in shock? Only 2 parameters what do you need to check for in a real scenario or in a cardiac arrest. Shock means systolic blood pressure should be less than 90 or the patient should be in altered sensorium. Okay, altered sensorium is because of reduced cerebral blood supply. That's what we are thinking about. It's most of the time it is the systolic blood pressure less than 90 what we are actually looking out for. Syncope. Syncope is transient loss of consciousness. Loss of consciousness. Any transient loss of consciousness in the recent episode, what has happened, then that is an indication or that is suggestive of life-threatening feature. Severe heart failure. This is not a known case of heart failure. Okay, he might be a known case of heart failure or it might be the first presentation. But if he is a known case of heart failure, it should be a worsening of the heart failure what the patient had. All right, if he's a known case. If it's not a known case, you need to look for has the patient has a pulmonary edema, suggestive of an left ventricular failure, or the patient has a right JVP, suggestive of an right ventricular failure. Okay, so 2 things you are looking for severe heart failure is the patient is in pulmonary edema, or the patient has a raised JVP. That is, raised JVP is distended neck vessels. Pulmonary edema is basically shortness of breath, low SpO2 values, and added sounds are seen on auscultation of the chest. Bilateral it will be. Bilateral basal creps, what will be heard in pulmonary edema, which we have learned in the last class. Myocardial ischemia. Myocardial ischemia, if there is an ST segment elevation on an 12-lead ECG, so it is a clear cut. Or the patient has a typical history of chest pain. So in a scenario, if they give an chest pain, that is enough for you to consider that patient as having a life-threatening feature. That's what you need to consider. Now, this one holds good. These are the same life-threatening features for both tachy and bradyarrhythmias. Let me summarize. Shock, systolic blood pressure less than 90. Syncope, transient loss of consciousness in that particular episode. Heart failure, a new onset of heart failure, either an left ventricular or right ventricular heart failure. Left ventricular heart failure is suggested by pulmonary edema. Right ventricular heart failure is suggested by raised JVP. Myocardial ischemia, you have a 12-lead ECG, clear-cut suggestive of an STEMI, then you have the diagnosis there, need not break your head. Or the patient even just having a typical chest pain is enough for you to think of a life-threatening feature. Now we are entering into an adult tachycardias. In adult tachycardias, everyone forgets the first approach is ABCDE approach. So airway, if the patient is hypoxic, supplement with him oxygen. Doesn't mean that in the question they have given an tachyarrhythmia. For example, they are given a ventricular tachycardia and it's hypotensive. I'll go and choose shock. The patient has a saturation of 80%. Start him on the oxygen first. Look at the airway first. Start him on the oxygen first. You are not jumping to treat something which is there in the circulation. Obtain, obtain an AV. This is airway and breathing. Here in circulation, obtain an IV. Access, get an ECG or connect him to the 12-lead, connect him to the 3-lead ECG monitoring or at least get an 12-lead ECG. Check for BP saturation. Saturation should be checked here itself. Identify if there is any reversible causes are there. It might be staring reversible cause might be present. Treat it first before even thinking about life-threatening features. Treat it first. For example, a patient is been known case of CKD come to the emergency department. Just now he got an potassium values done, which is suggestive of an potassium value of 8. So treat the hyperkalemia what is there. This is the first step. This is the algorithm taken directly from ALS. I have not made any changes here. That's why trust the algorithm what is given to you. Once you have done an ABCD approach, then ask yourself, is there any life-threatening features which we have discussed? Shock, syncope, MI, severe heart failure. Yes, there is one of these life-threatening features is present, then you are immediately shocking the patient. The thing what you need to remember here is it is a synchronized shock. In cardiac arrest, we always give an asynchronized shock or just defibrillate the patient, what we call it. We might not say asynchronized, just shock the patient, just defibrillate the patient, what we say it. When the patient is awake or he's not in cardiac arrest. What do you mean by not in cardiac arrest? That means he has an central pulse. If he has a central pulse, then you should always sync it. There is an importance for this syncing it. Why is it important for this syncing it? Okay, because you need to shock the patient just before the R wave. Okay, this is this is the Q wave what you're having. This is the R wave. Just before the R wave, you shock the patient. Okay, you need to shock it there. If you shock it somewhere, if you're not sync it, it doesn't sync it. If you shock it anyway, it can predispose to other arrhythmias like VF, and this patient can have an asystole and go in cardiac arrest. So you will be worsening the condition. To prevent the worsening of the condition, what you need to do is make sure you have pressed the sync button, which is there on the defibrillator. That is the importance of pressing the sync button. So do not forget, non-cardiac arrest patients sync. Cardiac arrest patient asynchronized. That's the difference. If this patient is awake, you cannot shock a awake patient. Sedate him. Who needs to sedate this? Anesthetic needs to sedate it. If unsuccessful, if unsuccessful after 3 attempts, you're shocked once, twice, thrice, still the patient is having life-threatening features and the patient is in tachycardia. At that point of time, you will give amiodarone. Okay, amiodarone is given over 20 to 30 minutes. Amiodarone bolus you'll be giving. Give the 4th shock. Still not reverted back. Start on amiodarone infusion. Seek for experts' help. That is, involve the cardiologist. You need to involve the cardiologist. Something seriously wrong here. You shouldn't be doing any heroic because you're already given 4 shocks. So sedate the patient, press the sync button. First shock, second shock, third shock, not improved. Then you will give amiodarone bolus, 4th shock, not improved. Then you'll start an amiodarone infusion and involve the cardiologist. There are no life-threatening features are present. Then what needs to be done is dealt in this file. Before I go here on this slide, you need to also remember the joules, what has been written here. If it is a broad complex tachycardia, 120 to 150 joules. It's a non-complex tachycardia, 70 to 120 joules. If it's a atrial fibrillation, maximum how much joules are present in the defibrillator, you can use it. One more thing what you need to remember, for example, first shock you are given 100 joules. There was no improvement seen. Then second one, usually you increase it. For example, you increase it to 120 joules. The third one, you increase it to 150 joules. There is no fixed ratio how much you increase it, but the recommendation is you need to increase it incrementally. Now, narrow QRS complex. That means there are no life-threatening features. These life-threatening features are absent. Okay. Then what you will be doing is get an 12-lead ECG done. On a 12-lead ECG done, see the QRS complex or a rhythm strip. Anything you can get it done. See the QRS complex. If it is less than 0.12 seconds, that means less than 3 small boxes. If it is less than 3 small boxes, then it is a narrow QRS complex, what we call it. If it is a narrow QRS complex, next thing what you need to ask about is the rhythm. Is the rhythm regular? If it is a regular rhythm, you will consider it as an SVT. First, you will be treating with an vagal maneuver. There are various vagal maneuvers which you can do it. Like an carotid massage, you can do it. You can apply a little bit pressure over the eyeballs. You can ask him to hold his breath and blow against the closed lips. You can ask him to hold his breath, take a deep inspiration, hold it, blow the air through an syringe and try to move the pistol of the syringe. You can ask it. So there are various vagal maneuvers what you can do it. If the vagal maneuvers are ineffective, that's when you will be giving adenosine. Adenosine first dose is given as 6 mg, unsuccessful 12 mg, unsuccessful 18 mg also can be given. This was included few years back. Before they used to say 6 and 12. Now they are telling 18 mg also can be given. So 6, 12 and 18 mg what you are giving. The adenosine half-life is very short. It is few seconds it is. Okay, the adenosine life is very short it is only few seconds. So you need to make sure you have a large bore cannula inserted in anterior cubital space. Then you give it in and fast flush push. After followed by this, a 20 ml of normal saline push needs to be given so that it reaches the heart in time and it's effective. There are certain contraindications for adenosine. If someone has an respiratory disorders, which are especially this someone who is having an asthma, you do not tend to give it an adenosine. Someone who is in case of an COPD, it is not well maintained. Adenosine should be avoided in those circumstances. So remember the contraindications. If the contraindications are there, then usually you go for rate control by using an beta blocker. What if you're given 6, 12, 18, still not improved? So unlikely it is an SVT. We are thinking about it might be an atrial flutter. That's why we will be giving an verapamil or a beta blocker can be given if it is ineffective. Still it is ineffective, then you are going ahead giving an synchronized shock. Okay, synchronized, again, it is a synchronized shock. Sedation needs to be given if the patient is conscious. So up to 3 attempts you will be trying, still failed, then you will be involving the cardiologist. Let them handle this case. Next scenario, narrow QRS complex, irregular rhythm, you're thinking it is an atrial fibrillation. Most likely it is an atrial fibrillation. We have discussed extensively in the cardiology chapter how to deal with an atrial fibrillation. Stick to that algorithm. The same thing what is mentioned here, more briefly they have mentioned it. We need to consider the time duration also, which was taught for you in the last previous cardiology class. Just stick to that. A broad QRS complex, which is regular or irregular rhythm. Broad QRS complex, regular rhythm, it can be an ventricular tachycardia treated with amiodarone. But recent studies have shown that amiodarone is not effective for an monomorphic ventricular tachycardia. What they suggest, monomorphic stable ventricular tachycardia, they suggest give sotalol or do an directly an electrical cardioversion. So in the options, if they are given sotalol or if they have given an electrical cardioversion, that is sync shock, if they have given, choose this over an amiodarone. If this is not given, only amiodarone was given and these two options were not given, then choose amiodarone. Sometimes it might be an SVT with an aberrant block. If you are sure it is an SVT with an aberrant block, then only treat it as an SVT or else treat it as an VT. Okay, treat it as a non-complex tachycardia if you are confident. Usually they say, if you read it here properly, if previously certain diagnosis of SVT with an aberrant block was present, then consider it what they recommend. All right. Now it is a broad QRS complex, but an rhythm is irregular. The possibility is it is an polymorphic VT. Polymorphic VT is treated by magnesium. Remember this, tested again previous diet itself. Or it can be an atrial fibrillation, where usually atrial fibrillation is a narrow complex because it's a supraventricular rhythm it is. But if it is associated with a bundle branch block, it can be a broad QRS complex plus irregular rhythm. If that is the scenario what you are having, then you will be treating it as an atrial fibrillation, what we have learned in the previous class, in the cardiology class. Let us quickly see and revise the ECGs what we have seen. There is no P wave seen, narrow QRS complex, then it is an SVT and rhythm is regular. This is sawtooth appearance what you are having, it is an flutter. Okay, flutter, we either treat it with verapamil or an beta blocker. Here, the rhythm is irregular, narrow QRS complex, no PVS is seen, it is an atrial fibrillation. This is VF. VF, I didn't say this can be an VF. Why I didn't say it can be an VF? VF means ventricular fibrillation. Ventricular fibrillation can't have an cardiac output. These individuals will not have an cardiac output. They are in cardiac arrest. So if you really go back to the algorithm, what we had, the first algorithm, what we had about the cardiac arrest, the important thing, what I want to stress here is it says only VF here, but it says pulseless ventricular tachycardia because cardiac output can be present in a ventricular tachycardia. Cardiac output cannot be present in ventricular fibrillation. It's just vibrating. The ventricles are just vibrating. It is not even contracting. How can you have an pulse at all? That's why it is not compatible with the life. The patient has to be in the cardiac arrest if he is in VEF. So this is what you are having as a VF. This is what you are having as a monomorphic ventricular tachycardia. This one, what we are having is a polymorphic ventricular tachycardia. This one, what we are having is an atrial fibrillation with an left bundle branch block. Why do I say it is an atrial fibrillation? I have an M pattern here. What I can see, a M pattern is present, which is suggestive of a left bundle branch block. I cannot appreciate any P waves. No P wave is present here. Along with it, the rhythm is irregular. This RR interval to this RR interval is different. So it is irregular. No P wave, irregular rhythm is suggestive of an AF, but this patient has a broad QRS complex. This is because of an bundle branch block. So this patient, I can treat it as just as an AF. Now we are entering into an adult bradycardia. Before I go in, anyone has any questions? All right, we'll enter into the adult bradycardia. Approach is similar to that of the adult tachycardia, what we learned. So ABCD approach, give oxygen if appropriate and obtain an IV access. Current the ECG monitor to get into valid ECG, current and non-invasive blood pressure and check for the blood pressure and saturations. Treat any reversible causes are there. Here only I want to make it a point. What point are you making a point here? What point I want to make it? A reversible cause. One of the important reversible causes, most of the time they tend to ask is beta blocker overdose. Remember, it is an overdose what I am talking about. Okay. Beta blocker overdose can cause bradycardia. So treat the beta blocker overdose by giving an glucagon here itself. You need not even look for life-threatening signs. Usually students will come and ask me, so whether to give an atropine or glucagon. Give an glucagon. It's before anywhere atropine comes. It's much before the atropine comes. All right. Next thing what you are seeing here is life-threatening features. It is same as tachycardia. Again, no changes for the life-threatening features what are present here. Yes, the life-threatening features are present. Yes. Then you give an atropine. Then you'll see how's the response. Usually the response will be immediate. You flush it in seconds till you recheck the blood pressure, all those, you should be able to see the response. There is no response to atropine. Then what you'll be doing? If there is no response to atropine, you have choices what needs to be done. You can give repeated doses of 500 max, that is 0.5 mg, repeated doses to a maximum dose of 3 mg, you can continue giving it. Or you can place it on transcutaneous pacing can be done. Or you can start on any of this infusion. What is preferred? The preferred one is atropine you are given, not responded. Continue atropine, giving atropine till you reach the maximum dose of 3 mg. Once you have reached the maximum dose of 3 mg, the next best choice is to do an transcutaneous pacing. If transcutaneous pacing is not working or you cannot do it for some reason, then drug infusion is the preferred. So remember, first you are given atropine 0.5 mg, not responding. Then you give one more 0.5 mg, one more 0.5 mg, up to 6 doses, which will become 3 mg, not responded. That's when you'll place this patient on a transcutaneous pacing. Or you're not able to pace on transcutaneous pacing for some reason, then you'll start on drug infusion. Next, again, I'll go back to the previous page. Life, there is no evidence of life-threatening features. There is no evidence. If there is no evidence, then you are looking for if there is any risk for asystole. Another thing is you are given atropine, there wasn't satisfactory response, then also you'll look for is there a risk of asystole. Risk of asystole is recent asystole the patient had. Okay, recently he had an myocardial infarction, or the block is morbus type 2 block, or he has a complete heart block with a broad QRS complex, or the ventricular pause is more than 3 seconds. We already know what is asystole, what is morbus type 2 block, what is complete heart block with a broad QRS complex, self-explanatory. What is ventricular pause for more than 3 seconds? In an complete heart block patient, if one bit, this is the one bit what we'll consider, and another QRS complex. So this is one QRS complex and this is another QRS complex. The time duration between this QRS complex, if it is more than 3 seconds, that is known as ventricular pause for more than 3 seconds. It usually happens in a complete heart block where the heart rate is on the very, very lower side. If yes, then again you will be intervening in the similar manner what I told for. Usually here what will happen? Here there is slight change. We are not again using atropine. Either we'll directly go for transcutaneous spacing or an drug infusion. Okay, that is the slight change what you need to remember. In spite of transcutaneous spacing and drug infusion, if they don't respond, experts help. Basically, cardiologist involvement for and transvenous spacing you will be involving. You need to remember the atropine dose as 0.5 mg, which is nothing but equivalent to 500 mcg. It is one and the same. Maximum dose what you are giving is 3 mg. That one also you need to remember. Infusions, there are various drugs what you can infuse like an adrenaline, isoprenaline, dopamine. This dosing you need not remember. This is not required. This for just for your reference. If you can remember, well and good. Okay. I do not recommend you to waste your time remembering the dosing. Those dosings are not required. Aminophylline, dopamine also can be used. Okay. These are the alternative drugs also which can be used. First, I'll be talking about transcutaneous spacing. I talked about transcutaneous spacing. I said after giving atropine, if the patient is not responding, you're given 3 mg of atropine, then you can go ahead with an transcutaneous spacing. How to do an transcutaneous spacing? First thing is in the defibrillator, you need to select the pacer mode. Once you select the pacer mode, there are two options usually which appear if yours is an expensive defibrillator. If it is not an expensive defibrillator, they may not give you these options. You want to select a demand mode or a fixed mode. There is a difference between demand mode and fixed mode. What is the difference between demand and a fixed mode? Demand mode. If the patient's heart rate comes, for example, you have set the heart rate as 70 per minute. If it is less than 70 per minute, then only it will give and generate an electrical activity to pace the heart. If it is not less than 70 per minute, it doesn't generate any electrical activity. For example, in this rhythm step, there is generating an electrical activity here, 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 because the heart rate is less than 70. Once the heart rate was more than 70, it has not generated. So it is demand mode. Whenever it is required, it will generate electrical activity. Otherwise, it will not generate. It will not act as a pacemaker. Fixed mode. Doesn't matter what the patient heart rate is. At a fixed interval, it will be generating the electrical activity. This is not preferred because if the patient heart rate increases and patient's electrical activity can overlap with the device electrical activity and it may not be helpful. It sometimes might trigger arrhythmias. So preferred mode is demand mode. Sometimes a demand mode might not be present in your defibrillator. Then you might have to just stick with what is present. That is a fixed mode. Then you need to place the pads. This holds good for cardiac arrest or AED. Everywhere you place the pads in the similar manner. One pad is placed just below the right clavicle. Another pad is placed in the mid-clavicular line in the fifth intercostal space. Slightly on the lateral side also we can place it. All right. So heart comes somewhere in between this so that it is shocked in between those two. If this position is ineffective, then we go for anterior posterior. Like this, how it is shown here, you will be placing it on the back side, just below the scapula. On the left side, you will be placing it just below fifth intercostal space, closer to the sternum, what you will be placing on the anterior side. This is known as anterior posterior pacing. If this is not effective, then you go for this position during pacing. I'll be talking about when we go for this position. So what we'll be doing? Once you have selected an pacer mode, then you have selected, for example, in these two modes, I have selected the demand mode. Okay, once I have selected demand mode, then you need to set an heart rate. Heart rate universally it is set to an 70. Okay, 60 is very close to an bradycardia. 70 is the ideal one what we feel. So we connect it to an 70. Then pacer output you need to select. What is the output? That is nothing but the energy of the shock what you're delivering. What you start it with very low, that is the 30 milliampules what it is recommended. Then what you'll be looking, you will be looking continuously at the monitor to see whether there is something known as electrical capture. What is electrical capture? Electrical capture is after every electrical activity which is produced by the pacer, there should be an QRS complex. There is absence of QRS complex here, absence of QRS complex here. That means there is no electrical capture. Here, after every after every electrical activity, there is a QRS complex. After every electrical activity generated by the pacemaker, there is a QRS complex. That is suggestive of there is an electrical capture. Okay, so you will incrementally keep on increasing this energy till you have an electrical capture. Usually we go by 30, 40, 50, 60, 70, like that you go till you reach the max. Max is around, it depends from manufacturer to manufacturer, is around 120 to 130 is the maximum what you can go. Once you reach the maximum, still you are not getting an electrical capture. What we will be doing at that point of time? At that point of time, you will be changing the pad positions to anterior posterior. Till anterior posterior you are done and you reach to the maximum energy, still you do not have an electrical capture. What does it mean? That usually means the cardiac muscle is non-viable. The cardiac muscle is already dead. Nothing much can be done. What does it mean? Is it safe for the staff member, the nursing staff, to nurse the patient when he's on an transcutaneous pacer? Absolutely safe. They can touch the patient. Does conscious sedation is required? Not a must that conscious sedation is required. Okay, most of the patients will tolerate it very well. If they're not tolerating it, then conscious sedation might be required. For conscious sedation, you need to involve the anesthetic. Okay, sedation basically we're giving. We need to involve the anesthetic. I just spoke about the electrical capture. There is one more capture known as mechanical capture. So what is mechanical capture? Once you have this rhythm, then you need to check for the pulse. The pulse should correlate with the heart rate what you have set. Pulse, you will be feeling it, but the pulse might be 35. That doesn't mean there is a mechanical capture. There's only electrical activity what is happening, but mechanical capture, the cardiac output is not there. That at that point of time also, you need to keep on increasing the energy till you get mechanical capture. So first what you are seeing is an electrical capture. For example, I'll consider at 50 milliamperes, I got an electrical capture, but I do not have a mechanical capture. So you will keep on increasing till you get a mechanical capture. Once you get a mechanical capture, you will be stopping it. Usually, practically, if you ask me, around 90 milliamperes, you get both electrical and mechanical capture. Special circumstances in bradycardia, I'm talking about. Special circumstances in bradycardia. So a patient has a bradycardia, has a life-threatening future. Along with it, the patient is having an inferior wall myocardial infarction or a spinal cord injury. Give first dose of atropine 0.5 mg, then directly jump to aminophylline. Okay, this is how you need to answer in the question. If atropine is not given, give atropine. If atropine, one dose of atropine is also given, the next drug of choice will become aminophylline. If the patient had an cardiac transplant plus bradycardia and life-threatening feature is present, then atropine is absolutely contraindicated. You will be directly jumping to aminophylline. The patient is on regular dose. I take one tablet of bisoprolol 2.5 mg every day. That is a regular dose. So the patient has on beta blocker, bradycardia, and life-threatening feature. This is not an overdose. He's taking his regular dose. Then you are giving first atropine followed by adrenaline, because atropine effect is not is kind of tapered, or it is not much effective when the patient is on beta blocker. That's why they recommend adrenaline infusion. First, you need to always give atropine followed by adrenaline infusion. Beta blocker or calcium channel. Beta blockers give glucagon, calcium channel blockers give calcium. These are the reversible causes, so that is the preferred one. Okay, do not get confused in the examination. These are the special circumstances, if present, I'm talking about. If not, you're sticking to what I have thought previously about the bradycardia. Just stick to it. Do not do any changes. Now we are entering into the pediatric basic life support. Pediatric basic life support is very much similar to that of the pediatric life support is very much similar to that of the adult, but has changes because of the age group. Okay. Sir, second pad, isn't it a mid-axillary line or mid-clavicular line? You need to place it where the apex beat is. Okay, usually the apex bit, you can place it more axillary. It is not mid-axillary line. You're not placing it completely in the axilla. Okay, it is not axilla what you're placing it. Okay, it is not about what you are thinking it is about what's the guidelines suggested. I'm talking about the guidelines, what is suggested here. Okay, I'm highly recommending everyone who are not aware, you're not 100% sure, do not confuse others. Coming back to the pediatric life support. Pediatric life support is very much similar to that of the adult life support what you're having. There are few changes what you need to remember. The patient is unresponsive. That means first you are gone for scene safety. The scene safety is present. Once the scene safety is present, then you are checking for the responsiveness. The patient is unresponsive. Once the patient is unresponsive, you immediately call for the help. Activate 2222. That means you are just calling the activate 2222. That means you are just putting out an cardiac arrest call out, which is the number which is commonly used in NHS. Once you have put this call out, you will open the airway. This is the difference what you need to remember. First difference we have here is to open the airway. How do you open the airway? Either you can use jaw thrust technique or head tilt chin lift maneuver. Head tilt chin lift maneuver is specific for medical causes. Do not use it for trauma. Then you will be checking, is the breathing normal? Breathing is more important. So second change here is you're looking at whether the patient is breathing or not. Because in pediatric age group, hypoxia is the one of the most important or one of the most commonest reversible causes for cardiac arrest. Okay, cardiac causes, for example, cardiac causes are very rare in an pediatric age group. It's mainly the hypoxia which causes the cardiac arrest. For that reason, you're seeing whether the patient is breathing or not. If the patient is breathing, then it is a medical emergency, not a cardiac arrest. So you're treating according to airway, breathing, circulation, deformity, and exposure. You are not sure whether the patient is breathing normally, or those are agonal breaths, or the patient is not breathing and is apneic. At that point of time, you need to give 5 rescue breaths. Okay. 5 rescue breaths are nothing but similar breaths. You open the airway, use an back mask ventilation, and give 1 breath over in 1 second's time and make sure the chest is expanding. Once chest has expanded, or you're not comfortable to give the breaths because you do not have an ambu bag, it's an out of hospital cardiac arrest, you need to give mouth to mouth respiration. You're not comfortable giving it for any reason, you can directly jump to cardiac chest compression. We'll assume that this is an we will assume that this arrest has happened in hospital and you have ambu bag available, bag mask ventilation is there, you're given 5 rescue breaths. After 5 rescue breaths, you will reassess and see how is his breathing. No, the breathing is still compromised. There are no signs of life are present. Then you'll start with chest compression. We have the next change here. That is the third change what we are having. Sorry, this was the second, this was the third, and this is the fourth change what we are having now. The ratio of compression to breaths. It is 15:2 what we are giving it. 15:2 what you need to remember. It is a 15:2 what you are giving it. After this, you need to connect the AED. A pediatric AED will be available. Connect the pediatric AED and follow the pediatric advanced life support. Let me repeat it. The things you need to remember, not the carotid pulse, it's the breathing what is very important. Along with it, 5 rescue breaths needs to be initially given before you start the chest compressions. 5 rescue breaths you are given, the compression to rescue breaths is 15:2 if there is no response to 5 rescue breaths. Those are the differences from the pediatric to that of the adult, what you need to be aware of. Next thing is you need to remember the mnemonic wet flag. It is very important. Whenever you get a pre-alert from the paramedic, you usually ask how old. They will give you an approximate age. They'll say it is a 4 years old kid, for 5 years old kid, 2 years old kid. Then you will be calculating the wet flag. Wet flag is a mnemonic to calculate important parameters which are required for the cardiac arrest. We need weight because all the dosing in the pediatric age group is according to the weight. Once you have the age, you can calculate the weight using one of this formulas. Do you have to remember these formulas? Yes. You need to remember these formulas. There is no giveaway. You need to remember the formula. What is the joules of shock what you will be delivering? Or the energy of the shock? 4 joules per kg. So you need to remember this one also. The endotracheal tube size is also important, multiple times tested, and it was tested in the previous diet also. Okay. Usually what they do in the exam is they do not mention whether it is a cuff tube or an uncuffed tube. If they're not mentioned anything, use this formula. If they specifically mention cuffed, use this formula. Uncuffed, use this formula. This formula doesn't hold good if the baby is preterm. Preterm. Okay, it was delivered at 34 weeks and it is 2 days old. This is still a preterm. Then use 3 mm uncuffed. 0 to 6 months, 3.5 mm cuffed. 6 to 12 months, 4 mm cuffed what you're using it. Length also can be calculated, but it is not very important according to me. You can skip it because they have the standard lengths most of the time. Fluids 10 ml per kg holds good for any scenario. If the patient is in cardiac arrest or in a shock, when you want to give a fluid bolus, it's always 10 ml per kg. Lorazepam dose is 0.1 mg per kg. Glucose is, I've just written 2. You can give it up to 2 to 5 ml per kg. Okay, 2 is the starting limit. Max is 5. So you can at once itself give 5 ml per kg of 10% dextrose can be given. I just mentioned 2, up to 5 also you can give it. Adrenaline needs to be given. It is 0.1 ml per kg of 1 is to 10,000 dilution. This whole parameter you need to remember, otherwise you get confused. In other words, it's 10 mcg per kg what you need to remember. If you're giving through endotracheal tube, because in pediatric age group, it might be difficult to get it. If someone has secured endotracheal tube, you don't have an IO also, you can give it through an endotracheal tube also. But the dosing changes. You're giving undiluted 1 is to 1,000 dilution you are giving it. 100 max per kg, 10 times more than what you give intravenously, you'll be giving it through an ET tube. And the dilution, remember that it is 1 is to 1,000 what you're giving through an ET tube, not 1 is to 10,000. This tubes, what I have shown here is, this is the cuffed tube and this is the uncuffed. This is known as cuff, which is present, which is absent here. That's why it is an uncuffed tube. Now in cardiac arrest algorithm, very much similar, nothing changes here. Okay. The only change is in BLS that we know 5 rescue breaths needs to be given first, then the 15:2 ratio. Then you'll be assessing the rhythm, non-shockable rhythm. Again, it is the same. There are no changes. That is PEA or asystole. Along with it, a heart rate of less than 60 is also considered as a non-shockable rhythm. Okay, remember that part. Again, go same. Adrenaline dose we are already aware of, that is 10 max per kg is the adrenaline dose, and you give it every 3 to 5 minutes. Absolutely no changes here. Shockable rhythm, again, is the same rhythms, VF or VT. We already know that the energy, the joules of energy for the shock is 4 joules per kg. 4 joules per kg, which you need to remember, you cannot escape it. Then you will continuing it, no changes there. After third shock, as usual, you will be giving adrenaline as well as amiodarone. The amiodarone dose is 5 mg per kg bolus what you'll be giving. After fifth shock, again, this is after third shock, you'll be giving adrenaline plus amiodarone. Then adrenaline will be continued every 3 to 5 minutes. Then amiodarone will be given after fifth shock. Again, same dose. Amiodarone dose also you need to remember. Okay, so amiodarone dose, adrenaline dose, and the joules, energy of the joule, what you're giving, you need to remember they can test you on this. Next one is tachy and bradycardia in an pediatric age group. Most of the time, you don't see an pediatric age group having an tachyarrhythmias or bradyarrhythmias. Most commonest arrhythmia is an SVT. Most commonest tachycardia is an sinus tachycardia, which you have learned in our cardiology class itself, which has completed. Okay. So as usual in an adult, you're doing an ABCD assessment, no changes there. If there is any signs of circulation, any That means, is the patient is in cardiac arrest while you're checking ABCD? No. If the patient is not in if the patient is in cardiac arrest, then you'll be following ALS algorithm. No changes what we have learned so far. If the patient is not in cardiac arrest, then you'll be seeing it is different, not life-threatening features. They call it here in the pediatric age group. They call it as an decompensated or compensated. Compensated basically means there is a lot of confusion here. If you ask me, there are a lot of confusion here. They're not very clear cut. What do they mean by decompensation? Because we are talking about bradycardia and tachycardia, and they have mentioned brady and tachycardias here. So what I recommend here is, if there is an syncope or there is an altered sensorium or the blood pressure is less than 5th percentile or capillary refilling time is more than 2 seconds or the peripheral pulses are weak, consider as an decompensated. Do not consider bradycardia and tachycardia as decompensated. All right. Let me repeat it. If there is a syncope or altered sensorium is present, if the capillary refilling time is more than 2 seconds or the BP is less than 5th percentile or the peripheral pulses are weak, consider as a decompensated. Do not consider brady and tachycardia as decompensated. Bradycardia is a very rare thing to find in an pediatric age group. So till now, they are not tested, not only for the MRCM level, for an FRCM level also till now, they have not been tested. Optimum oxygenation, if at all, if you come across a kid with an bradycardia, they think it is because of hypoxia. So treat the hypoxia, give the oxygen, what they say here. Despite oxygen, if the heart rate remains less than 60, they say start on CPR. Okay, that's why here in the algorithm, the previous algorithm, what I had here, I said bradycardia less than 60 is one of the indications to start the CPR. That's why they have mentioned here, the heart rate being less than 60, start the CPR. First, what you're doing, giving the oxygen. In spite of giving the oxygen, the patient is unconscious and the heart rate is less than 60. That's when you will go ahead and start the advanced life support for the patient. Okay, if you think there is an increased vagal tone, then you can give atropine. All right. Very rarely these persons will be required. Here itself in the algorithm, they required has suggested that very rarely pacing will be required. Otherwise, pacing will not be required. Next thing we are discussing about is SVT and sinus tachycardia. I want to compare and discuss with it. Okay. Whenever the heart rate is very high, like 200, which is might be a normal sinus tachycardia in an infant, you will not be able to appreciate the P wave. P wave kind of overlaps the QRS complex. You will not be seeing the P wave. So in an infant, what I recommend is look at the heart rate and decide whether it's a sinus tachycardia or the SVT. Do not depend on whether you are seeing a P wave or not seeing a P wave to differentiate between a sinus tachycardia and an SVT. Because when the heart rate is 200, you will not appreciate the P wave. So look at, if it's an infant, the age is mentioned in months, like 7 months, 6 months, 4 months, they are mentioned. You want to differentiate between SVT and sinus tachycardia, look at the heart rate. If the heart rate is more than 220, it is an SVT for you. If it is less than 220, it is an sinus tachycardia for you. If it is a sinus tachycardia, just treat the underlying cause. It might be because of crying, exercise, pain, analgesia. So you will be treating it. It might be something else also. For example, anemia causing a sinus tachycardia, hypovolemia. So treat the underlying cause. If it is an SVT, that means in an infant, the heart rate is more than 220, SVT. The preferred one is to give a synchronized cardioversion. At the same point of time, here is a point which is very important. Okay, if the patient is conscious, you need to give an sedation. You cannot give it, you want to involve the anesthetic. You're not able to readily get the anesthetic. At that point of time, you can use adenosine. Okay, adenosine can be used at that point of time. That point you need to remember. Synchronized shock is preferred, but for some particular reason, you're not able to give a synchronized shock. It is getting delayed. At that point of time, adenosine can be used. Broad complex and has decompensated kit, then you need to give an synchronized shock. If the patient is conscious, sedate him. Conscious, sedate him. If he is unconscious, without sedation also, you can give it. Okay, they say consider amiodarone before the third shock. Before 1 or 2 shocks itself, you will be involving the complete PICO team. They'll be down there to help you out. So unlikely they will test you more than this. What do you need to remember? Decompensated kit, VT, VT or SVT or any tachycardia is present other than sinus tachycardia, you will shock the patient. If the patient is compensated, okay, then for bradycardia, oxygen you will be giving. For SVT, vagal minima you will be doing. Okay, compensated means it has to be SVT or it has to be a sinus bradycardia. So vagal minima for SVT, bradycardia, you will be just, for bradycardia, you will be just giving an oxygen. So bradycardia, oxygen, SVT, vagal minima, what you will be doing. There are different doses what to be remembered. What I recommend, at least remember this. If you're able to remember all this, well and good, kudos to you. Please remember it. Uh, If you cannot remember it, at least remember this much what I have highlighted here. Adrenaline dose, amiodarone dose, shock. People get again confused here. In a cardiac arrest, you're giving 4 joules per kg. In a non-cardiac arrest, you're giving a synchronized shock. You start the first shock with 1 joules per kg, not responding second shock by 2 joules per kg. So you are incrementally increasing the energy, how you will increase in an adult itself. Okay, maximum you can go up to is 4 joules per kg. In a decompensated kit, I said that if the blood pressure is less than 5th percentile, it might be difficult for you to remember according to the age. If you can remember this, is very good. Okay, it's very important. If you can remember this, it will be helpful. It will be going long way. If you cannot remember this formula. So at least either one of this you remember. Formula gives an approximate value, will not give an exactly what is mentioned in this tabular form here. Approximate value you will be getting it, but it should be good enough for you to answer the questions. And in an emergency practice also, the approximate value should be good enough for you to treat. All right. Now we are entering into the foreign body. Foreign body aspiration. Okay. Again, this is covered in the ALS, pediatric and adult, what we'll be dealing with. Whenever you come across any person who has aspirated a foreign body, most of the time you'll come across out of hospital setting. Ask for help. Don't do the heroics. Ask for the help. Then assess whether the cough is effective. How do you assess? As a good cough, it's a loud cough what you are having. Then encourage him to cough. That will help him to get out the foreign body which is there in the airway. If the cough is not good, it is a that's not a good cough. Or a weak cry is present. He's hardly able to talk. That is not a good cough. At that point of time, if the cough is ineffective, you'll be checking whether the patient is conscious or unconscious. He might have been unconscious at that point of time. If the patient is conscious, for the child, what we'll be doing is you will be giving 5 back blows. Like this, like this, you'll be giving 5 back blows. Followed by 5 back blows, you're giving 5 abdominal thrusts, what you will be giving it. Abdominal thrust for the pediatric age group, you might have to kneel down to come to that level, and you're placing a fist just below the sternum and you're going backwards and upwards. You're going backwards and upwards. Okay, like this in the pic, in this way direction you will be going. You might have to kneel down because you need to get down to that level of the pediatric, that level of the child. What if it is an infant? If it is an infant, you will hold the infant in one hand, okay, and you will be giving 5 back blows like this. Once you are given 5 back blows, always check the oral cavity for any foreign body is present or surroundings if any foreign body has come out. If not, then you will be giving chest thrust. What is chest thrust? Chest thrust is similar to that of the CPR, what you are giving, but there is a little bit different. You're going little bit more deeper, you're going it here. Okay, in a pediatric age group, they say 1/3 the AP diameter of the chest, what you need to compress. Here they say you go more than 1/3 of the AP diameter, and you will be doing more with more energy, more swiftly you will be doing it so that there is increase in intrathoracic pressure and there is expulsion of the foreign body. You will be continuously doing it till the foreign body has come out or the patient has become unconscious. Once the patient has become unconscious, you are directly going ahead with the pediatric basic life support. Okay, pediatric basic life support, you are starting it. Remember that here unconscious, we have said, I have not said here, look for the respiratory efforts if they are present or not. I have not said that they look for any signs of life are present or not. You're just depending on the child being unconscious. Unconscious is enough for you to start the BLS. That's the difference. Usually people get confused here. Do not get confused. Next, adult choking. Very much similar. It is immediately call for help. If someone is choking, assess. For the cough, what do you need to assess? If the cough is effective, encourage the cough and closely monitor. If they are deteriorating and the cough is ineffective, but the patient is conscious, 5 backflows. After 5 backflows, always you need to assess the mouth to see any foreign body is there. If you're able to visualize the foreign body, then you can do a finger swipe. If you're not able to visualize the foreign body, do not do blind finger swipes. Again, I'll repeat, do not do blind finger swipes. Then again, you are doing an Heimlich's maneuver, that is nothing but abdominal thrust. Backwards and upwards, what will be going. Backwards and upwards, what will be going. 5 back blows followed by 5 abdominal thrusts. In between, always check for any foreign body which has come out in the oral cavity or in the surroundings. At any point of time, the patient becomes unconscious, then you start CPR. That is basic life support, adult basic life support you are starting. Again, I am not telling you to check for the carotid pulse. I'm not asking you to check for the life sign of life. If the patient is unconscious enough for you to start on the start on the basic life support. Do not forget, this is where people get confused. This point is important, tested multiple times in the exam. Few additional things. If you have appropriate skills, you are a good person who can do an laryngoscope. You can do an laryngoscope and see if you can visualize the foreign body in the airway and remove it using an Megel's forceps if you can visualize it. If the patient is unconscious and you have started a basic life support, tracheal intubation as soon as possible. If you're skilled enough, it is preferred. Okay, it is preferred to do an tracheal intubation. It is always preferred to do an tracheal intubation as soon as possible. It is the preferred method. Can anyone hear me? Yes. That is the preferred method, what you need to remember. All right. Why it is preferred tracheal intubation? The most of the questions will be for me is why it is preferred, doctor, why not? So this is the trachea you consider. Here is the foreign body what you are having. When you are intubating, you can use this ET tube itself to push this foreign body to in one of the main bronchus. Then you can ventilate one of the other lungs and save the life. Sometimes what will happen is this might not be possible. So this is the trachea what you are having. Here is the big foreign body which is stuck here and you're tubed. You're trying to back mask. You're not seeing any chest rise at all. The ET tube is not going further. You cannot do anything. At that point of time, front of neck access, that is tracheostomy needs to be done. Emergency tracheostomy, a surgical airway, front of neck access, what needs to be done. The last thing for today is about this X-ray. You got an X-ray done. Okay, this is a suspected case of foreign body aspiration. Aspiration I am talking about. Which side has the foreign body? This side has the foreign body. Why this side has the foreign body? Why not this side? Why? Because this you can see it is more black in color. This is more whitish in color comparatively I am talking about. Why this is black in color? This is because of hyperinflation. What has happened? If you consider this as an trachea, this is the foreign body. When you take a deep breath, that's when it gets sucked in into one of the bronchi. Okay, so the air gets trapped in and the foreign body obstructs it. So while you are inspiring, the foreign body gets get pulled towards that bronchi. That's why the air has got entrapped into the lungs. That's why it appears more blackish in color. So the side which has more black in color has the foreign body. What do you need to remember? So this ends the today's class. Anyone has any doubts, please do type. Happy to answer any of your doubts. I'm unmuting you, all of you guys. If you want, you can unmute yourself and ask me also. This is a very, very important class. Multiple questions will be appearing on this class. Anyone has any doubts, you can unmute and ask yourself. All right, we'll be stopping our class here. Thank you, everyone.